can see my slides, right? Okay, all right.
Hi everyone, a very good afternoon to all the GPs and doctors tuning in today. Welcome to CVSKL's Virtual Education Forum, this time focusing on cardiology. We are joined by Dr. Choo Gim Hooi and Dr. Suren Thuraisingham, who will be joining us later. A quick introduction on Dr. Choo. Dr. Choo began his career in cardiology in 1999 at the National Heart Centre Singapore and later at the National Heart Institute of Malaysia. Dr. Choo joined CVSKL as a consultant interventional cardiologist in November 2017 after having practiced for 14 years in KPJS Lengo and Subang Jaya Medical Centre. His academic credentials are worthy of note, having published peer-reviewed journals. Dr. Choo has also co-authored book chapters and some of the Malaysian clinical practice guidelines. He continues to be actively involved as a faculty member of many conferences and educational workshops in the field of cardiology, not only locally but internationally. Dr. Choo has leadership roles in the National Heart Association of Malaysia and Asia Pacific Society of Interventional Cardiology. He is part of the steering committee in our National Cardiovascular Database for PCIs and Malaysia's STEMI network. Dr. Choo will be speaking about managing residual risk beyond statins. Dr. Choo, whenever you're ready.
Okay. All right. Thank you very much, Brenda, and I want to welcome everyone who's here today. I see that we have, at the moment, 30 over participants. Thank you. It's, I think, some friends I can recognize from the name list. It's a pleasure to be able to share with you this afternoon regarding this topic, which is, I think many of you have seen me talking about statins in the past, but this is a slight twist from the statin story. Many of you have recognized me as a promoter of aggressive LDL cholesterol reduction, but I hope today to be able to look at a slightly different angle, to have a more comprehensive look at the lipid management to improve our patients' outcome. So let's look at how we can improve our patients' residual cardiovascular risk beyond lowering LDL with statins alone. So I have no conflicts to disclose for this presentation. Very briefly, we're just going to quickly look at why, again, atherosclerosis is the main concern and where LDL is linked to the pathogenesis and pathophysiology of disease. Therefore, LDL cholesterol should always be the primary therapeutic targets. I want, again, after that, to emphasize that beyond LDL cholesterol, our patients continue to have significant risk of cardiovascular events. So we need to do beyond LDL lowering with statins alone. Then we come to try to understand what we mean by atherogenic dyslipidemia. I hope to be able to guide you through some of the very basic understanding about how atherogenic dyslipidemia came about, and then from there you can understand the reason why we should be not just LDL centric, but also beyond that to look at the other components of the lipid profile. Of note would be the importance of high triglyceride or hypertriglyceridemia, and the importance of looking at not just LDL as a measurement for predicting risk and target, but also non-HDL. Before finally looking at some of the data behind reducing risk via the fibrates and omega-3 fatty acids. Right, I think it's always often been mentioned that all around the world, be it in developing or developed nations, cardiovascular disease remains the top cause of death. This is the statistics from about 4 years ago, but if you look at the projections in the next 1 to 2 decades, things are not going to change. Ischemic heart disease, cerebrovascular disease, both of which are atherosclerotic disease, remain the #1 killer worldwide. Closer to home, our latest census from the Ministry of Health shows in 2018, again, if you combine ischemic heart disease with cerebrovascular disease, 1 in every 4 Malaysians die from atherosclerotic disease. So let's look at then the underlying mechanism or the pathology. By looking at the plaque, there's no question that this LDL or cholesterol is the main culprit because it's the main constituent of the atherosclerotic plaque. And the link between LDL and atherosclerosis is actually irrefutable. We have lines of evidence from observations in epidemiological study like Framingham, many population studies, from genetic studies on the polymorphic gene polymorphisms that affect the LDL cholesterol, pathological studies, as well as interventional trials to try to lower cholesterol, which sort of close the link that LDL is a cause and effect relationship to atherosclerosis. When we started in the early days of statins, when we tried to be aggressive with the aggressive statin therapy, we clearly showed that aggressive doses of statin to bring the LDL as low as possible here in patients with stable chronic coronary disease, or we call it chronic coronary syndrome today, down to LDL 2.0 is translated to reduction in cardiovascular event. And we see the same kind of pattern when you treat patients in acute coronary syndrome in the PROOF-IT trial with aggressive LDL lowering. But then we also started to understand that as much as we can lower LDL with statins, there are many patients who continue to develop repeated events. This, of course, could be because these patients fail to meet the goals. We are not intensive enough in controlling the risk factors, including cholesterol. But sometimes, even at the best standards of care at that point in time, patients continue to have recurrent events. As you could see from this TNT trial curve that I showed you earlier, although we had a 22% reduction in risk of major cardiovascular events, these patients still have a very high residual event risk. Similarly, in the PROOF-IT trial, there's a very high residual risk even after aggressive statin therapy. If you look at some of these cohorts of people, this is from the cholesterol treatment trialist collaboration, where you look at patients with diabetes, even after treatment with statins, there is a high residual risk, which is even higher than non-diabetic patients who are actually not treated. So really, even after treatment for diabetic patients, the residual risk for the next cardiovascular events remain high. Then comes the story that is consistent, that every time we lower the LDL cholesterol, we find that we are able to further reduce the cardiovascular event rate. And this was seen in both primary and secondary prevention. The lower the LDL, the better, or the better reduction in events. The question then is, how far can you push this down? The best treatment to date that we had then was the statins, which could lower cholesterol up to 50 to 60%. But there are other agents available. As we had more of these agents in our armamentarium, we then tried to push the bar lower and lower. And so we had, at today's current state of possibility, we had azithromycin as well as PCSK9. There are a few other new generation pharmacological therapies which will be available in the next 1 or 2 years. Until then, we see that what we have today, like in the IMPROVE trial, where we had a combination of a statin with an azithromycin, we're able to bring the LDL as low as 1.4, and that was translated to a modest reduction in the primary endpoint, as well as the more commonly triple endpoint of CV death, non-fatal MI, and non-fatal stroke of about 10%. Then PCSK9 was as powerful as it could be, because on top of statin therapy, you could further reduce the LDL by 50 to 60%. And the Fourier trial truly exemplifies this, because we were able to reduce the LDL cholesterol from a baseline of 23 down to 0.8. And that was translated again to improvement in patients' primary endpoint event reduction. And with the classical triple endpoint again, we had a 20% relative risk reduction. So it is very clear that you can push it really low, and even in this exploratory analysis, when you lower the LDL down to 0.26, you had further reduction in cardiovascular events without any compromise in terms of safety. So this is where we are today in the 2019 iteration of the European guidelines for lipid management. We had outlined according to the patient's risk, which is determined by usually classical risk factor stratification. We had different thresholds of targets, which are based on the more recent trials. Again, we must emphasize that we want to lower the LDL. There must be first and foremost, a 50% reduction of LDL from the baseline before you look at the target goals. The other thing that has come about in the more recent guidelines is look at how diabetes is important as the modifier of risk. Many of our patients are diabetic, and the fact that they have diabetes alone actually amplifies the risk, telling us that we need to be very aggressive with the LDL lowering. So this is where, again, we have, until today, we've been looking at LDL cholesterol as the primary target. But now that we are able to get the LDL down to really, really extremely low levels or ultra low LDL, do we still need to look beyond LDL cholesterol to the triglycerides as well as the HDL? We have some indications here, again, from the PROVIT trial, up to the standards that were available at that time when they achieved the LDL goal of below 1.8. If the patient's triglyceride remain high, statin treatment still could not adequately reduce their cardiovascular event risk. But if the TG is normal, it does better. So statin may not be all the answer when the triglyceride is concomitantly high. Similarly, for HDL, in patients in the TNT trial who had already a low LDL cholesterol below 1.8, if the HDL remains low, they had a higher risk of cardiovascular events. So now I want to bring you to sort of expand your views beyond just cholesterol-centric world, that there is something beyond statins or LDL lowering. We have to look at the atherogenic dyslipidemia profile. Now, this basically describes a patient's lipid profile that constitutes fairly normal or just mildly elevated LDL cholesterol, but they had low HDL and high triglyceride levels. Even then, although we say that the LDL cholesterol is normal when you measure, the LDL is a bit different from the normal kind of raised LDL that we see, because in this group of patients, most of the LDL are the small, dense LDL particles, which are really the worst kind of LDL particles, apart from having a low HDL here and increased triglyceride-rich lipoproteins. Now, when we talk about small, dense LDL, the concept is that you may measure the same amount of LDL concentration in the blood, but the number of LDL particles may be different. If you have small, dense LDL, you have more particles to account for the same LDL concentration. So these are the LDL particles that are more atherogenic. In fact, this could also be measured by, if you have a measure of ApoB. Every ApoB measures every LDL particle. And the small dense LDL had a greater propensity to cross the endothelial barrier, to go into the wall of the artery, and hit there, they are more likely to be oxidized. And oxidized LDL is bad because they are more likely to be retained in the vascular wall and thereby promoting gradual accumulation and progression of the plaque. Now, atherogenic dyslipidemia is not uncommon. If you look at the whole spectrum of patients that have been treated with statin, whether patients with cardiovascular disease or high cardiovascular risk or diabetes, many of them have low HDL in the blue bar and high triglyceride in the red bar. This is especially prominent in patients with diabetes. In fact, we see that patients with diabetes or impaired glucose tolerance or metabolic syndrome, about half of them may have atherogenic dyslipidemia. Now, if you look at the prevalence of diabetes in our countries over the last 2 decades, the prevalence is actually increasing of diabetes. So this is going to be a big problem because we are going to see more and more patients with atherogenic dyslipidemia because of overweight issues as well as diabetes. Now, in the ECHORD trial, they look at diabetes patients. When you have atherogenic dyslipidemia, there is a great increase in the risk of cardiovascular events even when they are on treatment with statins. And there are also data to suggest they would have greater need for hospitalization and greater need for economic costs to take care of atherogenic dyslipidemia. So now that we have this idea that high TG and low HDL is bad, these two variables actually work synergistically to worsen the impact on excess cardiovascular risk. The higher the triglyceride and the lower the HDL, the greater the excess cardiovascular risk. But I want to just bring your sort of thoughts to our focus today. For many years, we have been looking at HDL, we're looking at triglyceride. Many of us still have the idea that if your HDL is high, your risk is low, and your HDL is high can actually negate a lot of the risk associated with high LDL or even high triglyceride. We have no time to go into the HDL story, but it's really a complex story. But today there is an emphasis to go more towards triglyceride because the HDL story hasn't borne out. A lot of the trials that tries to raise HDL did not show the reduction in cardiovascular event rates that we were expecting to see. Whereas with triglyceride, we have epidemiological data that says high triglyceride is an independent risk factor for cardiovascular event, and there's also genetic data as well with some of the gene polymorphisms which being identified. So we are now looking at a refocus on triglyceride rather than HDL. Although many a times we can't separate the two because every time triglyceride goes up, HDL comes down. And we will understand this right after this when I explain the pathophysiology of atherogenic dyslipidemia. The HDL, as we mentioned earlier, the trials that try to raise HDL hasn't been very fruitful, maybe because HDL is a very complex molecule. There are many variants of HDL that actually would have different functions. So not all HDL molecules are the same. And some of the agents that have been tried to raise HDL may have their off-target effects, which may have actually been the reason why the trials hasn't been successful. We haven't given up on HDL. In the coming years, we'll look at what we call ApoA1 mimetics, which may bring back the HDL story. But for now, triglyceride will be our main focus. Now let's look at why triglyceride-rich lipoproteins are bad. In the setting of diabetes or insulin resistance with metabolic syndrome, there is an increased free fatty acids that's derived from the breakdown of adipose tissues. These are taken up by the liver, and from there they are sort of made or produced into VLDL, which are high in triglyceride content. When the TG is high, it activates the cholesterol ester transfer protein. Now, this is a very important protein because this is really the key to the atherogenic dyslipidemia. Because this CETP basically transfers the high TG content of the VLDL to your LDL particles, whereas your LDL particles, which are rich in cholesterol, donates the cholesterol to the VLDL. In the process of this transformation, the LDL becomes the smaller and denser LDL, which are more atherogenic that we have described. The same kind of thing happens in the HDL side. The CETP exchanges cholesterol from the HDL molecule with the triglyceride from the LDL, which is donated to the HDL. In the same token, the HDL is changed to a smaller, denser HDL, which is less functional. This VLDL is also itself is changed. How is it changed? But before we go to that, so what has now happened is that we are now looking at a lot of triglyceride-rich particles, and these are the VLDL. When we talk about plaque earlier, we know that plaques develop when the LDL or cholesterol is brought into the wall. The VLDL particle is really a big particle, which is rich in triglyceride. It actually cannot go through the vessel wall to deposit its content. Triglyceride is not deposited in the arterial wall, so triglyceride is not actually the culprit or constituent of the plaque. But the VLDL, because of the exchange that we saw about in CETP, actually modifies the LDL. So in a normal state, when TG levels are normal, it is only the LDL that brings cholesterol into the vessel wall. And you can lower or reduce that risk by treating them with statins. Whereas the VLDL, which is rich in triglyceride, doesn't deposit the triglyceride into the arterial wall. Things are different, however, when your triglyceride level is high. When it's above 1.7, what happens then? Because of the exchange with CETP that we talk about, we have now more small dense LDL, which carries the cholesterol particle more easily into the vessel wall. At the same time, the exchange of the cholesterol with the triglyceride, with the LDL, changes the VLDL to what we call a remnant VLDL particle. This remnant VLDL particle is smaller and it can actually go into the vessel wall. Because it has received cholesterol from the LDL, that is then brought into the vessel wall. So now you have double jeopardy. In the high triglyceride state, you have not just the small dense LDL, but also the remnant VLDL cholesterol that brings LDL or cholesterol into the vessel wall. Statins can reduce the LDL content of the LDL, but it does very little to the VLDL. So statin treatment is not enough to reduce the atherogenic risk when you have a high levels of triglyceride-rich LDL or VLDL particles. Therefore, you really need an agent that can reduce triglyceride for effective management of the atherogenic particles. I hope that this is clear. If it's not, we can discuss this later on. So now let's come to the concept of non-HDL. And this becomes important when you have a patient that has a high triglyceride level. Because when you have high triglyceride level, especially above 4, your usual derivative, sorry, there's a background sound from the speaker here which is interfering. I hope it doesn't interfere with your voice there. When you have a high triglyceride level, the LDL that is usually derived from the lab studies, which is actually based on the Residual formula, doesn't hold true. So then we have to rely on another measure of the lipid, which is the non-HDL. Back in 2016, before the last ESC guideline in 2019, they already recognized that number one, triglyceride is important in terms of risk predictor, and non-HDL is a strong independent risk factor for cardiovascular events, especially in a setting of high triglyceride level. What is non-HDL? Simply put, non-HDL means total cholesterol minus your HDL. So that means we are looking at all these particles here, and these are the particles of lipoproteins that are atherogenic. So if you look at it properly, the atherogenic particles include all of these, and non-HDL would actually encompass all of this minus the HDL. So even when your LDL level is not clearly or accurately measured by calculation, this measure can actually do away with the need to look at the LDL level because it encompasses all the ApoB atherogenic lipoproteins. We have also data to suggest that non-HDL cholesterol level may be more predictive of cardiovascular or atherosclerotic progression than LDL level itself. In type 2 diabetic patients, once again, non-HDL cholesterol may be a better predictor of cardiovascular risk than LDL cholesterol level. So there are a few other reasons why we want to look at non-HDL, but basically, again, this is most useful when the triglyceride level is high, whereby the LDL that is measured in the blood by the Residual calculation is no longer valid or accurate. It doesn't require fasting to get a non-HDL level. It's easily calculated. When you use non-HDL as a target for therapy, basically you just add 0.8 to your target LDL. For example, if you're a high-risk patient and your LDL target is 1.4, your non-HDL target should be plus 0.8, which is 2.2. So that's how it works. This also has been recognized by a few of the professional bodies like the American Endocrinological Society, which has highlighted a non-HDL target goal, which is again 0.8 above the LDL target. A NICE guideline, they are always one step above the rest of, beyond or earlier than the rest. They are actually advocating non-HDL rather than LDL as the primary target of therapy for lipid control. So now let's come to how you're going to manage this atherogenic dyslipidemia. A lot of targets today has been focusing on the LDL cholesterol. There are a few other agents that can treat LDL, but let's look at beyond LDL. There are a few agents like fibrates, nicotinic acid, and CETP inhibitors. But today, nicotinic acid is gone. Nicotinic acid was supposed to be able to raise HDL and lower LDL, but because of the lack of benefits and some issues, it is no longer recommended. CETP inhibitors, no molecule of CETP inhibitors are no longer in development, again because of off-target effects, although one of the last CETP trials showed a modest benefit. So now we are only down to fibrates to treat the non-LDL component. So fibrates, if you look at it properly, it's actually quite good in terms of its ability to lower triglyceride level, even up to 50%, depending on the baseline triglyceride level. And the other agent that may be useful will be the omega-3 fatty acids. Let's look at the fibrates. Phenofibrates, we won't look into the studies in detail, but basically there were two big trials that look at phenofibrate. One was the field trial that was compared with placebo in diabetic patients who need not necessarily need a statin. And in this trial, it shows that there was a trend towards an improvement in outcome in all patients, but when the patients have atherogenic dyslipidemia, high TG and low HDL, there is a significant reduction in cardiovascular events. The ACCORD trial is a better trial because it looks at phenofibrate on top of statin therapy in type 2 diabetic patients with high cardiovascular risk. You find that patients with atherogenic dyslipidemia had up to 31% reduction in the triple endpoint of CV death, MI, and stroke. Here again, you've seen that I've showed you the importance of atherogenic dyslipidemia in increasing the cardiovascular risk. But in this ACCORD trial, again emphasizes that if you have no atherogenic dyslipidemia, adding a phenofibrate does not improve the patient's outcome. Only when they have atherogenic dyslipidemia, you have a significant reduction in cardiovascular event risk. Here again, in the same trial, you had a reduction in the other events, including cardiovascular mortality, but it doesn't improve the outcomes in those without atherogenic dyslipidemia. One other observation is the fibrates. What they do is not only lower triglyceride, but with regards to the small dense LDL, which is high in this group of patients here, marked in red is a small dense LDL. With 12 weeks of therapy with a phenofibrate, there is a change in the composition of the LDL, whereby there's a remarkable reduction in the small dense type of LDL and a lot more of the more buoyant and large LDL particles, which are less atherogenic. Accordion is basically a follow-on trial without treatment after the ACCORD lipid trial. 5 years after the study ended, they continued to observe the patients without treatment. It appears that those who have atherogenic dyslipidemia here, they continue to have a reduction event, saying that the phenofibrate addition to statin has got a legacy effect which lingers on. We see that it lingers on in terms of total mortality and a trend with CVD mortality as well. This so-called effect in atherogenic dyslipidemia of fibrates is seen across the board in all the fibrates, including gemfibrozil, bezafibrate. In the various trials, you see that it is most helpful when the patients have atherogenic dyslipidemia in the red bars. And here was the ACCORD trial. Just a quick words about fibrates are usually safe to be used, even in combination with statins, usually hardly any increase in side effect events, although an interesting observation of increase in serum creatinine level, though the field study suggests that the increase in creatinine level does not mean there's a worsening of eGFR. Here, after the drug was withdrawn after the washout period, in fact, the creatinine level or the eGFR was actually higher in the patients treated with phenofibrate against placebo. So the rise in creatinine that you see when patients are started on a fibrate does not necessarily mean there's a worsening of the eGFR. If you need to combine with a statin, phenofibrate is probably the safest of the lot. Please remember, gemfibrozil has a high risk of rhabdomyolysis when combined with a statin. I know that some of the public hospitals are still using gemfibrozil for cost reasons, but be very careful when you have to combine it with a statin. Now let's come to the omega-3 fatty acids. It's also a very useful drug to lower triglyceride. It's a useful adjunct. This story of EPA, eicosapentaenoic acid, comes and goes, but in the last 1.5 to 2 years with the REDUCE-IT trial, we have a definitive trial to show that omega-3 fatty acids in high doses, EPA, can lower cardiovascular event rate in patients with a high triglyceride level. But there are questions to whether the effect is only seen with a specific formulation of EPA and not all the other EPAs. Here you see that there's a very, very significant, a lot of zeros in front of the p-value for the reduction in the composite, primary, as well as the key secondary endpoint for cardiovascular events with the EPA addition to standard therapy. So this has also been added to the ESC guideline that in the patients with very high triglyceride, you may want to consider EPA at up to 4 grams a day to lower triglyceride level in combination with statins. We will have more data in the coming years from the strength and prominent trials that look at both the fibrates as well as EPA again to lower triglyceride and look at the cardiovascular outcomes. Reduce it is the one that we just discussed, which was truly and strongly positive. So ladies and gentlemen, I think what I hope we can take home from today's discussion is that please remember LDL will still be our main target for therapy because it is the main culprit in atherosclerotic cardiovascular disease. We are seeing an increasing number of people in whom the cholesterol, sort of atherogenic particles, are not carried within LDL but in the other triglyceride-rich lipoprotein remnants. So these are people with atherogenic dyslipidemia. We're seeing a lot of them in patients with metabolic syndrome and type 2 diabetes. And this atherogenic dyslipidemia basically constitutes patients with a high triglyceride, low HDL, normal or mildly raised LDL lipid profile. This atherogenic dyslipidemia is clearly associated with higher cardiovascular risk and increased need for hospital care and economic costs. Statin will still be the main first-line therapy in patients with atherogenic dyslipidemia, but when you have atherogenic dyslipidemia, you need to additionally lower the triglyceride level to be able to further reduce the residual risk that cannot be removed with statins alone. In presence of atherogenic dyslipidemia, non-HDL cholesterol may be a better measure of the patient's risk as a target for therapy. This non-HDL level of target will be 0.8 above your LDL target for every risk level of the patient. So a fibrate and statin combination will be very useful and it's evidence-based. It's been consistently shown to be useful in reducing cardiovascular events when you have the presence of atherogenic dyslipidemia. Fenofibrate may be the safest amongst the fibrates to be combined with the statin. Omega-3 fatty acid will be your next alternative if you need to lower the triglyceride further. Thank you very much.
Thank you very much, Dr. Choo, for the very insightful session. We do have a couple of questions from the participants. We have 3 questions. So for those who just tuned in, you are watching CVSKL Cardiology Virtual Education Forum. So Dr. Choo, back to our first question. Based on your recommendation, when do we need to start fibrate and what is the triglyceride target?
Okay, so again, to re-emphasize, when you have patients with cardiovascular risk or established atherosclerotic disease, statins come first. Bring the LDL down to the target level based on the patient's risk profile. Let's say 1.4 in those with highest risk, or even sometimes I target at 1, those who know me. Beyond that, if the triglyceride is still high, you know that these patients remain at higher risk for cardiovascular events. If the triglyceride is still above 1.7, then you might want to add on something to lower the triglyceride. It will be absolutely crucial to start a fibrate or something to lower the triglyceride if the TG is very high, for example, more than 4.5, because these patients are also at risk of pancreatitis. But let's say not that high, just slightly high, we must give the patients perhaps additional TG lowering agent that is either a fibrate or omega-3 fatty acid to further reduce the risk. And I would really like to target it to below 1.7. Now, having said that, I want to also inform that we don't start fibrate right away in this patient with mildly raised triglyceride because you know that statins can also lower triglyceride. So if you aim for high dose statin, it can lower the TG up to 30-40%. So that may be enough to lower the TG in your patients who have also high LDL cholesterol. Second thing is, there are a number of secondary causes of high TG. Lifestyle, like alcohol, patients who have, again, type 2 diabetes that poorly controlled, certain drugs, steroids and so on, that may also increase the triglyceride level. So make sure that you exclude those secondary causes first. And beyond that, if the TG is still high, consider adding a fibrate to lower the TG to the target level below 1.7. Okay, thank you.
Thank you, Dr. Choo. Second question, are calculated parameters like LDL and non-HDL reliable as markers? Will it be better if we measure the ApoB protein?
Very good question. So every LDL particle or every lipoprotein that is atherogenic that carries cholesterol has an ApoB protein there. So ApoB will be a very specific measure. For the higher the value of ApoB means the more ApoB particles, LDL particles, the higher the risk. So ApoB will be one way to get a measure of the patient's atherogenic risk. But ApoB is not that available or easily available in all your lab studies. Some of the lab studies do not include ApoB. So easier measure will be actually the non-HDL. A non-HDL will include most of your ApoB particles. But in a setting of, let's say, normal triglyceride, normal HDL, your LDL cholesterol level will be quite close to the real number of ApoB particles. So in most situations, in normal sort of dyslipidemia where you just have raised LDL, LDL cholesterol level measurement will be enough. When you have a high TG, then you cannot rely on LDL. You have to use either ApoB as a measurement or a more simpler one, just calculate the non-HDL level. Thanks.
Okay. One last question, Dr. Choo. Do you need to specifically measure the renal function once you start patient on fenofibrates or statins?
Okay, let's start with the statins. Statins do not worsen your kidney function, period. I'm sure you ask this question because you get the questions from your patients every time they come. I don't want to take a statin because it damages my kidney. That has not been demonstrated. All right, so that's clear. Fibrates, so statins can only damage your kidney if it causes severe rhabdomyolysis. That's only how it works. So by itself, it doesn't damage the kidney. Fibrates, as you can see, very often you'll notice that the creatinine level will rise. Well, it may be useful to measure, to sort of check it. If the level rises, you allow some rise in the creatinine level, but do not be alarmed and do not use the creatinine rise as a reason to stop your fibrate if it's necessary. But of course, if the creatinine rises too high, you probably want to look out for other causes of worsening renal function. So by itself, you can expect maybe a small rise, 10% at most, of your creatinine level with a fibrate, but do not get alarmed. Do not stop your fibrate just because the creatinine goes up. As I showed you earlier in the slide, in the field study, although the creatinine level was higher in patients who were given a fenofibrate against placebo, when they wash out, when they stop the fenofibrate, the creatinine level actually dropped, even lower than those who were given placebo. So we believe that the rise in creatinine due to a fibrate is not due to a reduction in EGFR. Thanks.
Thank you very much, Dr. Choo, for your time. For those who just tuned in, thank you very much for tuning in to CVSKL Virtual Education Forum focusing on cardiology. We will move on to our next speaker, Dr. Suren Thuraisingham. Dr. Suren graduated from the St. Thomas Hospital Medical School in London in 1985 and attained his MRCP in 1988. He went on to become a member of the Academy of Medicine in Malaysia in 1999 and was then awarded the Fellowship of the Royal College of Physicians in London in 2002. He has vast experience in all majors of interventional cardiology and has published more than 30 abstracts and papers in international peer-reviewed journals. His last appointment in UK before his return to Malaysia was as a registrar in cardiology in the Papworth Regional Cardiac Unit in Cambridge. Dr. Suren spent about 7 years as a senior lecturer and consultant cardiologist in University Malaya Medical Centre, before moving on to Sunway Hospital, where he spent 18 years. Dr. Suren joined CVSKL as a consultant interventional cardiologist, bringing years of experience to provide the best of heart care, treating patients and assessing them in healthcare Malaysia. Dr. Suren will be speaking about the role of calcium channel blockers in complicated hypertensive patients. Dr. Suren, whenever you're ready. Dr. Thuraisingham, we cannot hear you.
You're muted, I think.
Okay, now we can hear you.
Okay. 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 Sorry about all this. All right. Established cardiovascular renal disease examples like patients with previous stroke, coronary artery disease, infarcts, angina, atherosclerotic plaques, patients with heart failure, peripheral artery disease, and atrial fibrillation. Examples of complicated sequelae. Now, our jobs as doctors, first of all, we need to diagnose hypertension. We need to look for evidence of complications of hypertension so that we can initiate or identify these patients who require attention early. And then when confirmed, we need to treat blood pressure to achieve the targets that have been set out, which will enable us to achieve better outcomes for these patients who we diagnose. I would like to discuss a case which I hope you all will be able to participate in your little, wherever your settings at the moment. A 68-year-old Chinese lady who came to see me about a month ago. She had had ankle edema for 2 weeks, denied any chest pain, dyspnea, palpitations, or any other symptoms of note. She had had diabetes for 5 years and had discovered herself that her blood pressure was elevated when she went to a clinic. She went to a pharmacy about 6 weeks before, and she never checked her blood pressure for about 2 years before that. Her home readings, she immediately bought a BP set for home and had readings such as this, you can see on your screens, 145 to 160, 1995 diastolic. And she went to see a GP who put her on some medication, a once-a-day pill, 3 weeks before she came to see me. These were her blood results. You can see a low HDL in keeping with diabetes, slightly elevated triglyceride, and a moderate LDL. She had had asthma, which was mild to moderate in severity, and she had had a gastric ulcer, but otherwise no other medical issues in the past. Her BMI was elevated at 29, and her BP in the clinic was 150/100. Pulse was 80, and there was no JVP elevation. Her heart sounds were normal. The lung fields were clear, and she had occasional bronchi audible. Nothing else sinister in the examination. There was ankle edema, which was just above the ankle, and it was fitting, non-tender, and the skin and the quality of the skin was normal color. This is the ECG. Would you like to just make a note of your personal feelings about this and what you think this represents? Basically, this is a typical ECG of somebody who has left ventricular hypertrophy. You can see the tall QRS complexes here, the kind of non-symmetrical T-wave inversion, which is due to subendocardial ischemia, some people think, or we call it strain, which is probably not the right term. So this patient demonstrates left ventricular hypertrophy, and this is her chest X-ray. Now, strictly speaking, the CTR, or the cardiothoracic ratio, is not enlarged, but this kind of bulgy left ventricle, left heart border is quite common in patients who have borderline cardiomegaly, or especially in hypertension. Remember that left ventricular hypertrophy does not itself cause cardiomegaly. It's an ECG, more precisely, it's an echocardiographic diagnosis, right? This lady had normal renal function. Her liver function was as stated here. There was mild gamma GT and ALT elevation, which we tend to see in fatty liver changes. And her urine protein and albumin was completely clear. There was no, there was the blood albumin and protein levels were normal. There was no hypoalbuminemia. The urine contained 2 clusters of protein with no other abnormal cells, and the HbA1c was slightly up at 7.1%. So in summary, this lady is stage 2 hypertension. We'll go into that in a second. with a high global risk because of diabetes, low HDL, and proteinuria, with evidence of left ventricular hypertrophy. So significant hypertension has probably been present for some time and has already had, she's had features of hypertension mediated organ damage, which is a criteria that requires our attention. So what was the most likely cause of her edema? I think as a cardiologist or as a physician in a hospital setting, the most common reason we see this is due to drugs. Certainly, unless you're running a heart failure clinic with lots of patients with congestive heart failure, the most common reason for patients coming in with this isolated complaint of ankle edema is usually due to calcium channel blockers. Though steroid patients on steroids and BPH drugs for prostatism, testosterone, estrogen, antidepressants have all been linked to presence of ankle edema. But by and large, calcium channel blockers are the biggest culprits, and the dihydropyridine group is particularly notorious for this. Congestive heart failure, obviously, venous insufficiency, renal liver causes where the protein is low and hence a lower oncotic pressure in the capillaries will lead to leakage and hence ankle edema. In her case, we'll come to that shortly. So the diagnosis of hypertension in this situation. This is the NICE or NICE guidelines from Europe, and basically how we should approach the assessment of a patient who comes to the clinic with elevated blood pressure is systematic and should be something we should all take great pains to establish properly. So if the pressure is low, you really need to only keep an eye on the pressure once every couple of years, maybe even up to 5 years in younger people. But if they're near the borderline, more regular blood pressure checks are required. If the BP is between 140 to 90 to 180, 120, then on the first initial consult, we're not going to lead to any treatment, especially if there's no other evidence of other sequelae or effects from hypertension, HMOD, as I mentioned earlier, and certainly the patient has got no manifestation of cardiovascular disease. And here are some of the options we can have. It's become increasingly fashionable over the last few years to encourage home blood pressure monitoring or ambulatory BP recordings. And the criteria are pretty much the same to make a diagnosis based on these modalities. Of course, if the BP is very high, more than 180, 120, after repeated checking in a proper setting, which I'll not go too much deep into detail about, then suffice to say, we probably need to start treatment, and even more so if there's evidence of end organ damage. So these are the European Society of Cardiology definitions of hypertension, and I draw your attention to 130, 139, and 85 to 89. This area is high normal, but has been a zone of contention between Europe and America and over the years by how aggressively you deal with these patients, and I'll go into that in a little more detail shortly. Grade 1 hypertension is 140 and above, and 90 diastolic and above, and henceforth. You can see that on the screen. Now, I think taking hypertension in isolation is wrong because it is one of the players that contributes to overall cardiovascular risk alongside many other risk factors which you're all aware of, like diabetes in this lady's case, family history of heart disease or premature cardiovascular disease, hyperlipidemia, and their lifestyle, smoking, etc. So it's important to also assess these patients, especially those in the borderline areas, for their concurrent risk profiles. And as you can see here, somebody with a high normal blood pressure in that 130, 139 zone, if they have risk factors, it puts them into a different therapeutic bracket for us to need to entertain. And obviously, the more risk factors you have and the more established disease you have, the higher the blood pressure and the higher the risk. These are the ratings of these patients based on their global risk. Very high risk patients, obviously diabetes with target organ damage, severe chronic kidney disease. The score thing here is a useful thing, especially for those in borderline territories, to see whether they should be considered at elevated risk for initiation of treatment. And as stated here, in decreasing risk groups, patients with significant elevation of a single risk factor, again, diabetes is a major player in global risk contribution, LDH, etc., etc. This risk calculator can be downloaded. It's called the heart score thing, and it's useful for general practitioners to have around, because patients presenting early with hypertension would be good candidates for you to consider treatment should they score highly in this. Don't forget, in Asia, those from Indian backgrounds are the highest risk in this area, and there's a 1.4 times multiplication factor on top of the score that is used in Europeans or Caucasians. And the Chinese, on the other hand, population are at a half the risk, so you can actually use this to help guide your decision about whether to consider them high or low risk. The thresholds for treatment have changed over the years. As I said, the high normal threshold group should be considered for treatment if they're in the high risk category. And the other criteria haven't changed much. BP in elderly patients in the 140 to 160 zone should be treated, provided that treatment is well tolerated. And I think each patient is different. We should not be using blanket criteria across the board for all our patients. That's where our skills as doctors come in. So what are options for treatment in this lady in particular? We all know the benefits of blood pressure treatment for patients. Even a 10 millimeter drop produces significant reductions in systolic blood pressure, will reduce coronary heart disease, stroke, renal failure, and all-cause mortality. So there's no need for me to harp on this fact. I think all of us are aware of the importance of blood pressure control. Even in patients with no previous cardiovascular disease, there's a significant reduction with BP treatment of just a 10 millimeter reduction in pressure. So latest fashions for blood pressure management are encouraging the use of combination treatment, especially with the targets being set lower than before. Trying to use combination pills, combining 2 or 3 drugs in one pill for improving compliance. And psychologically, patients like the idea they only take one pill, and that looks after all their blood pressure, and it makes it easier to increase doses because they still come in the form of one pill, and there are multiple available combinations of antihypertensive agents now, fortunately. So when it comes to this lady, I will share my thoughts with you, but basically in 2017, the AHA, American College of Cardiology, came up with a very simple approach. You can start any patient on the first drug, basically from any of the classes, except beta blockers. So beta blockers have been demoted in large majority of patients, but any one of the other options are fine as first line. The Europeans and the British came out with a slightly more nuanced approach, selecting the RAS targeting agents and or calcium channel blockers in patients who were without diabetes or with hypertension as a first line. Now, we don't see large Afro-Caribbean population in this country, but still calcium channel blockers play a large role in my personal practice as first-line drugs. But if there's any evidence of renal disease or history of cardiovascular disease or other manifestations of cardiovascular disease, I always like to use something that targets the RAS. So combinations of these are very popular and probably most effective. We can go on an add-on method by adding on thiazides, and as a fourth line in refractory patients, spironolactone or alpha blockers are recommended. Now, the freshest set of guidelines came out earlier this year by the International Society of Hypertension that looks in a more global pattern across different populations with different socio-economic backgrounds. And they go with the original recommendation that any first choice antihypertensive, first choice drug can be used in hypertension management. But if you were going for optimal drug selection, again, recommendation of a low dose dual therapy using a RAS targeting agent, either ACE inhibitor or ARB with a calcium channel blocker is preferred, and then stepping up the dose, and then, as I mentioned earlier. So this is the optimal lineup for hypertension in the modern setting. We are aware of ACE inhibitors and their impact on hypertension management from the early 90s, late 90s, and ACE inhibitors compared to placebo. Obviously, I'm not going to go into each of these trials, but this is a summary. Against placebo, obviously hugely effective, but compared to other antihypertensive agents, the major results, major outcomes are about the same, comparing these different drugs here, but there's a slight flavor towards renal benefits in patients on ACE inhibitors compared to other antihypertensives. Likewise, angiotensin receptor antagonists again come out favoring renal indices and long-term renal outcomes, but apart from that, no other major cardiovascular endpoints are achieved, are different between these treatment modalities. The most impressive study using this was the ASCOT study, which actually showed reduction in mortality, a combination of perindopril, an ACE inhibitor, and amlodipine combined versus atenolol and a thiazide. We would obviously like to use drugs that are most appropriate for our patients' particular medical issues. And there are certain antihypertensives that have flavors that favor certain situations. And there's been data to support calcium blockers, ARBs, and ACE inhibitors for left ventricular hypertrophy. As I said earlier, ACE inhibitors and ARBs are good for renal conditions. And for pure power blood pressure reduction, calcium blockers are probably the most effective, and hence they achieve their greatest help in patients with stroke reduction. And I won't go into all of these, but basically there's a flavor towards kidney benefit from ACE inhibitors and general cardiovascular nourishment with ACE and ARBs, where calcium antagonists and thiazides really are powerful sledgehammer drugs that really get the blood pressure down. So a combination of these two is nice. You achieve delicate effects of the RAS system, and you have pure blood pressure reduction and its obvious benefits with calcium blockers. So a combination of power and elegance, Nadal versus Federer would be a nice example in my mind. And calcium antagonists, as I said, are very well tolerated. Power blood pressure reduces, and they're cost effective, and they really have few compelling contraindications, especially the dihydropyridine group, which are really the main players in hypertension management. Here are some examples of how calcium channel blockers are very effective compared to other classes of antihypertensive, especially for stroke, as I mentioned. Less so, perhaps, for all-cause mortality. But calcium channel blockers are also most frequently seen in meta-analyses for their effective BP reduction compared to other modalities. So that's a combination of RAS targeting and pure power calcium channel blockers. And they are favored in many combinations alongside thiazides. Personally, I do not like thiazides in single or dual combinations, but as a third combo, member of the combo, yes, I like thiazides in that role, because I've had more than a few patients with hyponatremic problems, and not so much hypokalemia, but hyponatremia is a particular concern of mine, especially in the elderly. When they have any other GI upset, they tend to have crashing sodium levels. So my drug of choice would be a combination of calcium blocker and ACE ARB. And what targets do we have? Essential to get the blood pressure below 140/90, but as mentioned earlier, high-risk groups and those who tolerate medication well, we should try and get it as low as possible. And certainly below 130/80, but more than 120/70 would really achieve maximum benefit from antihypertensive therapy. In the elderly, we take a more cautious approach, obviously. Now, focusing more on calcium channel blockers, they've been around for many, many years. Initially, we used first-generation drugs which were poorly tolerated with lots of side effects, and then came the slow-release ones, and then the third-generation drugs, which include drugs like Residual, the carbamazepine, Zanidip, which is one of the drugs we'll focus on today. Side effects of amlodipine, which is probably the most widely prescribed antihypertensive, is irritatingly ankle edema, less so flushing, palpitations, dizziness, but ankle edema is a very common finding, especially high-dose amlodipine. Lecanidipine or Zanidip is the third-generation calcium channel blocker, dihydropyridine group. It has certain features that make it ideally suited for hypertension management. It does not induce reflex tachycardia, unlike the earlier short-acting dihydropyridines. This is a study called the cohort study that compared it with amlodipine in an elderly population, and you can see that the BP reduction was equal to amlodipine. In the challenge study, a group of patients who were experiencing side effects of vasodilation on these second-generation drugs, amlodipine, clozapine, nifedipine, and when they were challenged with lecanidipine in place of these drugs, they were observed and then re-challenged with the original drugs. And you could see that during the treatment with Zanidip, there was a significant reduction in ankle edema, headache, and flushing side effects. Result of this, patients, as we know, if you tolerate the drug well, you have no side effects, you're happier on that medicine and more likely to stay on that medication long term. And it's very, very important for hypertension management that we have compliance and adherence, because that is the key to long-term well-being. The DAL study looked at proteinuria in patients who were hypertensive with diabetes, and it compared lecanidipine to ramipril or tritase, which is a well-known effective drug for reducing proteinuria. And they achieved these following targets, and after 52 weeks, were both equally effective in blood pressure management, and the protein decrease in albumin excretion was statistically not different from that of ramipril. So this is a class of calcium channel blocker that actually reduces protein excretion from the kidney in patients with proteinuria. I mentioned compliance, and long-term compliance is critical in blood pressure management, compliance with therapy, I mean. So level of compliance is associated inversely with avoidance of hospitalization due to cardiovascular morbidity. And this is a study that shows that patients who come off their treatment, as you know, will suffer a greater number of events, and stroke risk goes up by 28%, and likewise MI hazard ratio goes up when they come off their antihypertensive medication. So 2 years, those who are non-persistent with their therapy had a 15% greater risk of MI and about 30% stroke increase. Zanidip is a better tolerated drug, as I mentioned earlier, with reductions in all these side effects that are commonly seen with dihydropyridines. And edema, again, 51% down. This is a unique property of this agent that contributes to this beneficial effect, is that it causes pre and post capillary dilatation, so you don't have an increase in the hydrostatic pressure. I think I'll skip some of these slides. The way it works on the kidney is that it dilates both the afferent and efferent tubules, hence reducing the intracapillary pressure and reducing proteinuria. So my take-home messages really are: make sure your patient has hypertension and deserves to be treated. So our selection, our knowledge about the patient's blood pressure is important, whether we gather it in the clinic with repeated readings or with home blood pressure measurement. So we need to make a diagnosis and stick to that diagnosis and follow up with appropriate treatment in the full awareness of the patient's full cardiovascular risk profile. Combination pills are preferred, and be cautious with the elderly. Use calcium channel blockers for more oomph. Ensure lifestyle measures are maintained throughout since after their diagnosis is made. Make sure you know each patient's personal target BP in the context of their profile. Try and use drugs that will ensure long-term compliance, and consider calcium blockers for effective and well-tolerated BP control. And that ends my presentation. Thank you. Any questions?
Thank you very much, Dr. Thurae. We do have a couple of questions for you. As lecarnidipine has renal protective effect, is it suitable for severe CKD patients with GFR of less than 30 mils per minute?
That's a good question. Certainly, most calcium channel blockers are safe, and whether it's going to serve any particular benefit from the proteinuria angle in severe CKD, probably not, but it is certainly safe to be used, yes.
Okay, our last question for today, if nobody else wants to add. So we are still taking questions via the Q&A function in Zoom. In your experience, how long does Zanidip takes to work in comparison to amlodipine? Do you switch to lecarnidipine if patient experiences ankle edema? And if yes, how do you switch?
Good question again. As I said, my number one prayer is that Zanidip comes in a combination with something someday soon. At the moment, because of the combination therapy angle, there are not that many patients who we can try Zanidip on, because kind of patients who come to us usually need double or triple therapy. And hence, for economics and other factors, we don't have Zanidip on its own that often. But if I have a patient who's on amlodipine alone with good blood pressure control, and they come to me with ankle edema or some other side effect, I will put them on Zanidip. The BP effect is immediate. Their pressure will be good the next day, and they very rarely develop any of the side effects. So they don't need a second drug. Zanidip is very effective, and there are two strengths. So even at 20 milligrams, you don't see much ankle edema as a solo standalone therapy.
Okay, it seems like there are no more questions from the participants, so we will end today's session. Thank you very much to all the GPs who tuned in today. There's close to 50 of you guys who spent your afternoon with us. So just to recap, Dr. Choo.
At the start there, I'm very sorry. What's the problem with my Zoom today? Apologies to all.
All right, just to recap, Dr. Choo spoke about managing residual risk beyond statins. Dr. Thurai spoke about the role of calcium channel blockers in complicated hypertensive patients. Thank you all for tuning in. Have a lovely weekend. Thank you, Dr. Choo. Thank you, Dr. Thurai.
Thank you. Thanks, Brenda.
Bye.
Bye, everyone.